Hello, my dear friends. When I started this case, I had no inkling to what extent this case is going to push me, because this seemed to be a soft cataract with a well-dilating pupil, and under slit lamp evaluation seemed to be just about a grade 1 nuclear sclerosis with a few cortical opacities. Capsulorhexis went out pretty well. I got a moderate size capsulorhexis of more than 5 millimeters. However, when I tried the hydrodelineation, it just wouldn't happen in spite of the fact that this was a soft cataract. And it's at this point that the red flags should have gone up, because only in cases of a gummy soft cataract would hydrodelineation not be possible. However, I finished off with cortical cleavage hydrodissection. I noticed the iris behaving in a very funny fashion. There was fluttering of the iris, and that's when I thought that this patient could be having a certain degree of floppy iris as well. So what you are going to see is my soft chop technique, because I did not get a hydrodelineation wave and a golden ring reflex. The power which I use is about 20%, and with moderate vacuum I bury the tip into the nucleus, and then using my dual linear foot pedal I increase the vacuum to 300 and then effect the chop. So using these dual settings, I'm able to create a crack and a separation in the soft lens, and I was pretty sure that I'm going to be able to complete this case with considerable ease, because everything seemed to be going well. When we apply topical anesthesia, we know it breaks down the mucin layer of the tear film, and hence you see that there is an oily sheen on the corneal surface that can sometimes impair the visibility. The floppy nature of the iris is becoming more and more evident as I proceed with the case, as iris keeps getting sucked into the phacoprobe. So the soft chop has worked pretty well, but in spite of this, as the pupil was shrinking and I formed a crater, I decided to do the visco-levitation of this nucleus girdle that is left behind. Please note that as I inject, the epinucleus shell is rising up, but at this point something else happens. This epinucleus shell has pushed my cannula out of the capsulorhexis, and then I end up injecting the visco through the zonules, and that creates something like a viscodeviation syndrome, where the viscoelastic has gone through the zonules and under the posterior capsule, leading to a small pupil and a flat chamber. At this point, I did not recognize this. I simply thought that there was a capsular block causing the lens to rise up. So I thought if I was able to split this lens, the visco will escape back and the chamber would form. But this did not happen. The pupil was extremely small and I kept digging around. What gave me a lot of encouragement was the fact that I have created at least 4 to 5 chops. I then decided to dial the lens, thinking that it would break the capsular block, but what it did was it pressed on the posterior capsule and actually corrected some of the viscodeviation, to my great surprise, and it also brought the chunk of nucleus for easy removal. Therefore, I dialed it to a favorable position, got hold of a huge chunk of nucleus mass, and because I had initially created the crack and separation, I was able to get these nucleus fragments out with phacoemulsification. So what was perplexing in this case was the fact that a simple visco elevation actually worked against me. During cortical aspiration, I found that the central part of the posterior capsule had come forward, and therefore the peripheral anterior capsular lip and the posterior capsule were kind of plastered together, making it very difficult for me to get at the cortex. This is where the coaxial IA or the bimanual IA construction works. The aspiration part of these instruments have a blunt closed proximal end, and the aspiration port is actually a millimeter above it. So if you point it down, you can use the blunt end to push the capsule downwards, and then the aspiration port, which is about a millimeter ahead of it, can aspirate the cortex. So use the beautiful design of both the coaxial IA as well as the aspiration port of the bimanual. Use the blunt surface of these instruments to gently push back the posterior capsule to gain access to peripheral cortex. Finally, the intraocular lens is injected and everything goes well in spite of a slight hiccup which I did not even anticipate. I'm using the pivot rotation and the shoulder of the optic of the IOL to actually iron out the posterior capsule and cause the visco to escape. And once I do this, the chamber is nicely formed. Thank you for your attention.